Hello, my name is Mary Jones and I work at the Swansea Centre for Health Economics at Swansea University. And today I'd like to speak to you about the cost effectiveness of the use of radiotherapy in addition to stent placement for patients with advanced stage esophageal cancer. This was a collaborative project funded by the NIHR Health Technology Assessment Programme. WES researchers, myself included, based at Swansea University, gave the initial advice. WES is funded by Health and Care Research Wales, and then we also undertook this economic evaluation. But as you can see from this slide, we had many collaborators working with us. So we had several different universities undertaking different aspects of the project. This was a large clinical trial with many different slants on the analysis. And we also worked with NHS Tayside, who were responsible for collecting the clinical data that we used to populate our model and that was used in the clinical trial. There are over 9,000 new cases of esophageal cancer and 8,000 esophageal cancer deaths in the UK each year. It's the 7th most common cause of cancer deaths, the 4th in men, accounting for 5% of the UK total. The majority of cases occur in those over the age of 60 and overall prognosis is poor, with 5-year survival rates of only 15%. The majority of patients present with incurable disease and mean survival in advanced disease is 3 to 5 months. The emphasis of treatment for most patients is therefore on effective palliation. Between 70 and 90% will require intervention for dysphagia. This particular symptom has profound impact on physical independence, social functioning and other aspects of quality of life. Interventions to improve swallowing must therefore aim to produce prompt and lasting palliation of dysphagia while minimising the need for late reinterventions and hospitalisations. The aim of this economic evaluation is to assess the costs and cost effectiveness of using external beam radiotherapy in addition to stent placement to improve patient-reported dysphagia at 12 weeks following stent insertion in a participant population unable to undergo surgery. In order to conduct this health economic evaluation, we started by doing a model-based cost-utility analysis. Incremental cost-effectiveness ratios, or ICERs, were expressed throughout the project as cost per QALY gained. So we look at the difference in costs and divide by the difference in QALYs, or in effect, and this gives us our ICER. We built a combined decision tree and Markov model to assess the cost effectiveness of the use of external beam radiotherapy compared to standard care for patients suffering with end-stage esophageal cancer with a time horizon of 12 weeks. For the first 2 weeks, patients are assumed to have a stent inserted and receive standard care, taking into account patients who die in this time period based on actual trial survival data. The stenting and any other treatment received was costed and patient quality of life calculated. At the beginning of week 3, patients are split into the control and intervention groups, with the control group receiving usual care and the intervention group receiving usual care plus external beam radiotherapy. Weekly costs and utilities are calculated. At the end of week 4, all radiotherapy is assumed to be completed and patients are assigned to one of 3 Markov states. Their dysphagia worsening, their dysphagia improving or remaining stable, and also a death state. The patients then move through the model for 8 weeks with a cycle length of 1 week based on transition probabilities defined by the dysphagia and survival data from the trial, with costs and utilities calculated weekly. At the end of the 12-week time horizon, all costs and utilities are totaled for both intervention and control groups. An ICER was calculated to determine cost effectiveness. Transient probabilities, costs and utilities are used within the model. The clinical trial data was used to populate the model. The external beam radiotherapy group had 97 patients and the comparator group, the best supportive care, had 102 patients. A UK NHS and Personal Social Services perspective was adopted with a 12-week time horizon. This was increased to 12 months in a sensitivity analysis just to capture any downstream costs. The clinical trial data was vast. It was collected fortnightly and included things like resource use. So this would include the implementation costs for the intervention group, also any healthcare resource use for both intervention and control groups down during the 12-week period. EQ5D data, which is the questionnaire used to evaluate quality of life. dysphagia scores and other physiological variables. It was a huge task for to unpick these data. If we begin by looking at resource use and their associated costs, resource use was calculated fortnightly on an individual patient level basis throughout the 12 weeks of the model for both intervention and control groups. These costs were then split by the dysphagia level of the patient, so whether they had worsening dysphagia or improving dysphagia, and then these results were fed directly into the model itself. This chart here just shows the overall costs and resource use then, and you can see that the main driver here is secondary care costs, but the intervention group have this large chunk of intervention costs also. Patient level utilities were calculated every 4 weeks for the different Markov states within the model. In order to use utility scores in the Markov model, we calculated utilities for each Markov state at each particular time point. Patient mean interpolation was used to populate any missing data while the patient was alive, and once the patient died, a utility score of 0 was assumed for that patient for the remainder of the time horizon. Utilities were calculated based on individual 4-week follow-up periods between baseline and week 12 for each of the states in the Markov model. At baseline, 12 weeks and 12 months, there wasn't a lot of difference in quality of life scores for the external beam radiotherapy group or the best supportive care group. Finally, looking at the results for the dysphagia and survival transition probabilities, there was very little difference between the transition probabilities, both for the different states of dysphagia and also for the transition to death for the external beam radiotherapy group or the best supportive care group. Finally, to check that our models are robust, we always undertake sensitivity analyses. For this particular model, we undertook a vast number of probabilistic sensitivity analyses, including varying costs and QALYs by up to 30%. We used an extension of the time horizon from 12 weeks to 12 months to ensure we didn't miss any downstream costs in the initial analysis. We also looked at using just complete case data or using just all cases, and always the conclusions did not change. A probabilistic sensitivity analysis was also conducted to see whether, if we sample each of the costs and each of the utilities from a probability distribution independently, whether we get a different change in the conclusion. Once again, in the vast majority of cases, we did not get a change in the conclusion. I hope that during this presentation you can see what value we add as health economists to a clinical trial, but I just wanted to pull out a few of the main points just to reiterate. First of all, we analysed the resource use and associated costs of all aspects of the patient's treatment pathway each fortnight during this particular project. This enabled us to really see where there were peaks and troughs in cost data and resource use, so that we could ensure that resources and their associated costs were not wasted. We did a similar thing with utility data. We took an in-depth view of all of the data. We made sure that we could see any nuances within these data. For example, often when an intervention is applied, you'll see an increase in the utility score. A patient immediately feels better, but it's interesting to see whether that utility then tapers off. And since we looked at the utilities each fortnight, we could do that. Decision analytic modelling captures the variability present within the clinical trial data, so we can make sure that we are as representative of reality as is possible. Also, the sensitivity analyses that we conducted check how robust the model is itself, and therefore how robust the conclusions we draw are. So we can test certain parameters to ones whether we maybe don't have too much confidence in, if we've made any estimations or anything, and we could test that to ensure that the model is robust to deal with these estimations. So the key message is understanding the cost effectiveness will help us assess the value of external beam radiotherapy compared to the best supportive care. So in conclusion, the main trial paper has been accepted and approved by NIHR. The cost effectiveness analysis has been submitted for peer review, so watch this space for publication for the main conclusions. Thanks very much. Diolch yn fawr.